Hello, I'm Dr. Kathleen Pace Murphy, Assistant Professor at the University of Texas Health Science Center Medical School, Division of Geriatric and Palliative Medicine. On behalf of our Principal Investigator, Dr. Carmel Dyer, I'd like to introduce you and welcome you to the Houston Geriatric Education Center and the Baby Boomer Imperative course. I first would like to acknowledge the Houston Geriatric Education Center's funder, the United States Department of Health Resources and Services Administration, or HRSA, grant number UB4 HP 19058. The Baby Boomer Imperative Project was possible because of this funding. The learning objectives for this 40-hour course include discussing the general principles of aging, identifying the basic principles of geriatric medicine, including geriatric interprofessional assessment, geriatric pharmacotherapy, geriatric syndromes, specific non-pharmacologic interprofessional interventions for older adults. We will be discussing preventative care, chronic disease management, rehabilitation, palliative, and hospice care. And lastly, we want to discuss geriatric care in the acute hospital setting, office practice, long-term care, and also aging in place. Why do we bother doing this? Well, we know Americans are living longer, and as Americans age, we're going to see more chronic diseases and disabilities. We know that 1 in 5 Americans will be eligible for Medicare by 2030. In 2030, 20% of our U.S. citizens will be 65 and older, and now is the time for us to plan for this cohort of people. Well, so what? Americans are aging. Why should I be concerned about this? Well, as an interprofessional healthcare provider, think about the number of 65 years of age and older adults that you currently see in your practice. For example, we know that 26% of all physician visits are people over the age of 65, 35% of all hospital stays. Prescriptions make up 34% of people over the age of 65. Emergency medical responses, 38%. 90% of all people in nursing homes are over the age of 65. And we know that 80% of people age 65 and older require care for chronic conditions such as hypertension, arthritis, and heart disease. Who's going to take care of the baby boomers and this growing boomer population? Well, currently, we have 7,500 allopathic and osteopathic certified geriatricians in the United States. One full-time geriatrician can care for approximately 700 patients in their panel. We need 17,000 geriatricians right now to care for the current 12 million older adults. Well, that's just physicians. Thank goodness for interprofessional geriatric teams. Well, unfortunately, less than 1% of RNs, pharmacists, and physician assistants are going into geriatrics. Approximately 2.6% of advanced practice registered nurses are in geriatrics, only 3% of psychologists, and approximately 4% of social workers. The world's population is aging. When we look at longevity, defined by Farini and Farini in 2000, it's length of life. However, this rather meager definition does little to expound all the factors, interests, and questions that surround long life. Factors that influence longevity include things such as heredity, gender, ethnicity, marital status, social economic status, psychological characteristics, culture, environment, and lifestyle. The dynamic influence and impact of these factors and others only exemplify the complex nature of studying the aging process and caring for people over the age of 65. We hear all kinds of terms when we talk about aging, age and old, and I think about the age at which one is considered old really depends on the age of the person actually using the word. Old is generally thought of as an age beyond one's own. Most elders do not consider themselves old until they become sick or dependent upon others. So these terms can be limiting. So one of the things that we'll talk about as you view many of our modules is that there's different ways to define aging. You have chronological age, functional age, psychological age, the third age, the fourth age, young old, middle old, old old. But what we know is there are profound differences between individuals of the same age, and that's one of the first concepts that one must recognize when dealing with people over the age of 65. We need you. We need you to join us to care for our precious resources, our elders. Some of the global aging trends that are important to think about are the decline in fertility and mortality rates. In 1950, 8% of the world was greater than 60 years of age. We project in 2050, 21% of the world will be age 60 and older. It will be the first time in history where older adults exceed the number of young. Currently, we have 759 million people older than the age of 60. In 2050, there'll be 2 billion. This graph represents young children and older people as a percentage of global population from 1950 to 2050. On the x-axis, you see the age, and on the y-axis, the percent. And what you can see is that when you get into the area of 2010 to 2020, you see the continuous growth of the 65 and older population represented by the orange line and the diminishing green line of people under the age of 5. Older populations will increase more rapidly in developing countries than in developed countries. As you see on this global population growth, this is the developing country phenomena. In the green, it represents developed countries, which is relatively flat, and the exponential growth in developing countries of persons over the age of 65. This slide shows the percent increase in populations aged 65 and older from 2008 projected out to 2040. The growth of this aging population will challenge government resources, healthcare resources, government infrastructure, and social dynamics. As you look at this, you can see the percent increase in population in countries such as Japan is 30%. Currently, 1 out of 4 persons in Japan is over the age of 65. But then look at countries such as China at a 209% growth, India at 274%, and Singapore with an incredible 316% increase in the population age 65 and older. Now we'll look at the highest national life expectancy at birth from 1840 to 2000. We've been looking at how age is affecting the makeup of this population. But when we look at life expectancy, you can see that life expectancy is increasing for both men and women, men being represented in green and women in the orange. As you look along the x-axis, you see age, and then in the y-axis is in years. Currently, the overall life expectancy now in 2010 is 78.7 years. For women, their life expectancy average is 80.8 years, and for men, it is 75.7 years. Life expectancy at birth for selected countries by region in 2008 shows that in countries such as our own in the United States, the average life expectancy at the 2008 year was 78.1 years. Look at these countries and how their life expectancies are now increasing, with Costa Rica at 77.4 years, Chile at 77.2, Argentina 76.5, and then countries such as Guatemala at 70 years of age and Peru at 70.4 years. And knowing from the previous slides that these age life expectancies are increasing every year in these developing countries. So what do you think will be the global aging challenges? Why don't you take a minute and write down a couple thoughts. What about financing health? Long-term care services, how will they be provided to such a large cohort of aging persons? How do we care for rural and remote healthcare services to people who are not close to large urban centers to require medical care? How do we offer health services to people that live in rural areas to allow them to age in place? Multi-generational households are becoming more and more common. How do we deal with the unique problems or challenges that multi-generational households may have, caring not only for young, middle-aged, college-aged, and then those over the age of 65? How do we use our country's resources to help with retirement and for these long periods of time that people are not productively working after they retire? And will we have enough trained healthcare workers to care for this aging cohort? The U.S. demographic trends are very interesting. One of the things that we've noted is that older U.S. adults are not evenly distributed throughout the United States. In fact, 50% of older adults live in 11 states. The top 4 states are California, Florida, New York, and our own Texas. With the wonderful economic boom that we are currently experiencing here in Texas, we expect Texas, because of the number of people moving to our state, to increase significantly in the top 3. So there's also changes in the U.S. demographic trends by ethnicity and race. Currently, white older Americans are the majority, especially in people over the age of 65. But we know that Black older American population is going to increase by 50% over the next 10 years. Asian Americans and Hispanic American older populations are anticipated to triple. Hispanic Americans' older population will exceed the Black older population by 2050. Education has been always an important social economic factor to look at, and it's especially important in older adults. Between the years 1965 and 2008, the percentage of people greater than 65 years of old who completed high school increased from 24% to 77%. For bachelor degree completers, it went from 5% to 21%. So we know that education is closely related to lifetime economic status. As the baby boomers age, we will be aging with a group of people that do have a higher level of education and a higher level of economic resources. Think about all the changes that have occurred for people that are in the baby boomer era. We selected, for example, just music to give you an idea of the vastness of changes that have occurred. In 1950, we had Elvis. The Beatles and the British invasion occurred in the 60s. Then we went to disco and the Bee Gees. The 1980s brought punk rock and the 1990s rap, and currently we're in a country music phase. So there are many cultural, social, economic, moral changes that have occurred over these past years. And with this aging cohort comes many changes with them. Changes due to aging can really be divided into primary aging and secondary aging. Everyone is dealt their specific genetics, and we know that genetics plus environmental factors can affect how a person ages. But there's also secondary aging that we have to consider when we're looking at older cohorts. How do the people adapt to the changes of primary aging? What are their behaviors? What are their emotional states? What are their psychological states? And all of these biopsychosocial factors play a role in whether people have a beneficial, neutral, or maybe an unsuccessful aging experience. Aging is heterogeneous, and we talked about that a little bit before. When you look at a 75-year-old, I bet in your mind you can think of a 75-year-old that you know that is climbing mountains, is very active, and just continues on, and aging is no problem for them. But then we also see people at the age of 75 who are aging, who have chronic multiple morbidities, many medications. They appear frail, have trouble with getting around, and need of assistance from family and friends to actually age. So one of the things we'll talk about over this 40-hour course is looking at people that view aging from a beneficial, a neutral, or actually as a disadvantage. The fastest growing cohort of people are those that are 85 years of age and older. And with that, again, there's specific challenges that we have to look at. We have to think about, how do we finance pensions for people that are living 30 years past their retirement dates? Where do we find enough health services to take care of their increasing health service needs? Healthcare and disability services will become incredibly important. Will we have enough people to do not only disability services on an outpatient basis, but if people after the age of 85 have to stop driving, will we be able to provide those services in their home? Look at the number of people that are unpaid informal caregivers, family members and friends that provide care for people over the age of 85 without reimbursement. The changing market needs will be tremendous as the baby boomers continue to age. How about transportation, housing, and infrastructures that will be needed to support this large group of people? And then there's always the graying political lobby, which will be very important. When we look at trends in health, functioning, and mortality, one of the things that you'll see is some of the different kinds of diseases that are very specific, if you will, to aging. Some of the most common self-reported conditions include hypertension at 56%, arthritis at 51%, heart disease at 30%, cancer at 24%, and diabetes at 20%. Now let's look at the 10 leading causes of death among those Americans age 65 and older. The top 5 leading causes of death are heart disease, cancer, lower respiratory disease, stroke, and Alzheimer's disease. Note here that Alzheimer's is ranked number 5, above diabetes, and has increased in its ranks over the last 10 years. And you will see in the next slide that between 2000 and 2010, the age-adjusted death rates for cancer, heart disease, and stroke dropped more than 30% for the population as a whole. Looking at the top black bar between the years 2000 and 2010, the age-adjusted death rate for Alzheimer's disease rose nearly 40%. Let's talk a little bit about the terms successful versus unsuccessful aging. And let's start with unsuccessful aging. Let's consider these facts. For persons that might be having an unsuccessful aging experience, we know that they oftentimes have overt diseases that lead to frailty. Frailty is a new term, so let's define it. Frailty is a very important geriatric syndrome. Frailty involves things such as unintentional weight loss, exhaustion, low physical activity, weakness, and slow walking speed. It can lead to things such as poor functional status, that is, the inability of a person to care for themselves or the inability to do your activities of daily living. Frailty can lead to high levels of dependence. It can lead to social and societal withdrawal. Many people have a prolonged dying phase because of this, and the quality of life of a person who has an unsuccessful aging experience is often poor. When we look at successful aging, it is without overt disease. People have good physical and cognitive function, a high level of independence. They're actively engaged with broader society, and often have peaceful deaths without a prolonged dying phase. This is a guiding model of the Center for Disease Control's Healthy Aging program. This slide represents a guiding model that the Center for Disease Control utilized for healthy aging programs. They look at optimal aging and identified 3 tenets: promoting health and preventing injury and managing chronic conditions, optimizing physical, cognitive, and mental health, and facilitating social engagement. This graph shows chronic disability and the decline of it in the United States from 1982 to 2005. So all hope is really not lost. What this is showing is actually an increase in non-disabled people. Evidence of healthy aging is about us. Healthy aging encompasses more than just physical health. And I want you to remember that a healthy aging plan of care has to include social, emotional, economic, spiritual, and environmental components for us to help our older adults age successfully. This map of the United States specifically looks at data on caregiving by states and territories. So the map is 2009 data, and it shows the variability across states and territories, which varies from a low of 16.5% of caregiving in Wisconsin to a high of nearly 35% in Mississippi. And as we talked about a few slides ago, remember that there's a higher concentration of older adults in 11 states. And as you can see, for those of us that live in Texas, we're at the 26.6% to 27.4% marker currently. But we expect that to increase and change again with the growth into Texas. Let's talk a little bit about illness in older adults. One of the things we know is that diagnosis becomes more challenging in illness in older adults. Why is that? Well, older adults present in very atypical presentations and often have unspecific or non-specific, if you will, presentations. Their therapeutic pathways are less clear, and that's why geriatrics becomes a more specialized field. Some of the features of illness in older adults, as I mentioned, is the atypical and non-specific presentation. As we know, there's greater morbidity and mortality as we age. Many times disease or illness progress much more rapidly. There's health, social, and financial sequelae. Well, what do I mean by that? Well, oftentimes our older adults have trouble getting transportation to see their healthcare provider. Often, patients are living by themselves and don't have anyone checking on them to recognize there might be problems with cognitive impairment. Financial sequelae is quite common. People living longer, especially into their 80s and 90s, find that their financial resources are becoming limited and have to make decisions, for example, on whether to eat or to get their monthly medications. And there's also the lack of physiological reserve. So the question you might be asking yourself is, well, what is physiological reserve? Hopefully this next slide will provide some information. All humans have functional reserves, which means the body or the organ system's ability to function above and beyond what is used in ordinary activities. Functional reserves become called upon when physiologic, emotional, or other types of stressors present themselves. It's really your ability to help you maintain physiological homeostasis. As we age, we tend to utilize more of our usual reserves to maintain our day-to-day activities, and that diminishes our functional reserves. In older adults, this can manifest in really various clinical settings, such as delirium from a urinary tract infection, or postoperatively after a hip replacement after a patient has fallen. Treating disease in older adults can be a challenge. We can't always use the clinical guidelines that are published by many of the different organizations. We know that life expectancy and balancing risk and benefits has to be considered in decision making. Function is often the goal and is more important to the patients than extending one's life. We know there's more adverse events to therapies, especially pharmacotherapy. Sometimes, especially in patients depending on different pharmacological principles, they respond to treatments less immediately and less effectively than a person that's middle-aged. So all of these factors become very important for us as we move forward in treating disease. Chronic disease management will become a tenet of geriatric specialists. Approximately 60% of the adult population has a chronic disease. Multiple chronic diseases lead to complex healthcare plan of cares. Emphasis always needs to be on proactive management and certainly preventative care as well. Because we are associated with HRSA, we like to make sure that you're aware of all the wonderful resources that are available. We selected today just some resources from the Center for Disease Control. These resources are invaluable to you as you practice and move forward with taking care of older adults, and we strongly encourage you to utilize them. They're free, and the patients really will benefit as well as your practice. Sit back and learn. Enjoy the Baby Boomer 40-hour online program. Please engage us. Let us know how you like these modules. If you have questions, please review our website at https://www.hgec.org. And again, on behalf of Dr. Carmel Dyer and all of our faculty at the Houston Geriatric Education Center, welcome.